Hello and welcome to Group 9, Left Hip Fracture with Josephine Walker. Alright, case overview. Patient is a 98-year-old female. She fell in the kitchen while cooking and sustained a left subcapital hip fracture. She went through cemented bipolar hip arthroplasty, and this was completed 1 day status post the fall. Her cognition is intact and problem-solving skills are functional. Status post the THA, patient has decreased independence with bed mobility, transfers, ambulation, functional activities, and activities of daily living. Patient is on Tylenol 3 as needed and Fosamax. Prior medical history: she has osteoporosis for 25 years. She has a history of congestive heart failure, cataracts in right eye, appendectomy 60 years ago, and 10 uncomplicated childbirths. Her prior function: prior to the fall, patient was independent in all basic functional activities and was able to ambulate without assistive devices. She is a retired dressmaker but continues to make all of her clothes as well as make gifts for family birthdays and Christmas. She attends church every Sunday. She participates in bingo and senior exercise classes at a local senior center, and patient relies on family members to drive her to social events.
Okay, so now we're looking at the patient after her surgery, and we're looking at the ICF model. So for body function structure, she has pain at rest of 3 out of 10, which increases to 5 out of 10 with mobility in her left hip. She has decreased flexion, extension, and trunk. Basically all movement in her trunk is decreased. Her hip flexion and extension strength is decreased, along with her internal and external rotation in both of her hips. Her ankle plantar flexion and dorsiflexion is decreased. She has minimal right lower extremity edema. She has hamstring tightness in both of her legs. Patient has decreased hip extension and flexion in her left hip. She has left hip abduction and adduction decreased, but this may be limited due to her edema and sitting for the test position. Her internal external rotation is decreased, along with knee flexion and extension in her left lower extremity. Decreased foot and toe range of motion in bilateral lower extremities. Hip abduction and adduction is decreased bilaterally, along with knee flexion and extension. She has severe left distal lower extremity edema, and also her equilibrium and protect extension reactions are also delayed. For activity, she now requires a walker to support her, and she's partial weight-bearing status in her left lower extremity. She requires mod assist plus her walker support to maintain static stance and ambulate 15 feet. She requires mod assist in all bed mobility. She's also mod assist in all of her transfers, except toilet transfers where she requires max assistance. She requires min assist for wheelchair activities due to verbal cueing, so she doesn't run into the walls. She requires max assist for leg rest, placement, and maneuvering. She requires mod to max assistance for standing washing. And she requires max assistance for dressing her lower extremity. She also requires max assistance to complete her hygiene while toileting. For participation, patient is unable to attend her weekly bingo classes now. She's also unable to participate in her exercise classes that she was doing prior to her surgery. She's unable to get into her church due to steps that are limiting her, and she's also limited in her family activities, such as playing with her grandchildren.
All right, now we're going to talk about environmental factors. She lives in a mother-in-law suite alone and is separated from her son's house. She only has a traditional tub and shower for bathing, and she is not allowed, or she's not able to go to church because of the multiple step center. Personal factors: she is a 98-year-old female and falls into the oldest old category. She has osteoporosis. The patient has a history of cataracts and congestive heart failure. She has a family which is in close proximity, and she has good support, which is great. The patient has intact long-term and short-term memory. For the problems list, patient has difficulty stepping over standard bathtub in and out. She has pain at rest, 3 out of 10, and 5 out of 10 with mobility or range of motion in the left lower extremity. She has severe left lower extremity distal edema, minimal on right distal lower extremity. Patient is partial weight bearing on left and requires a walker with moderate assistance to stand and ambulate 15 feet times 3 with shortness of breath. equilibrium and protective reactions are delayed.
Our plan of care for this patient, the patient will be seen by an outpatient physical therapist 3 times a week for 4 to 6 weeks. At that point, the therapist will reevaluate to see if she needs further physical therapy or where she needs to go. Physical therapy will include 2 days in the outpatient clinic and 1 day in aquatic therapy. Preventative and restorative techniques will be included in all PT treatments. Treatment will include improve range of motion in left lower extremity and trunk, increase strength bilaterally in lower extremity and trunk, improve static and dynamic balance during sitting and standing, improve mobility, go up and down stairs to participate in church, gait training, decrease pain during rest and activity. Patient will be educated on fall prevention and how to scan left to right, secondary to the cataract in her right eye. Home modifications will be suggested as needed, including modification to her standard bathtub to a walk-in shower that doesn't have a high step, so she's able to do that independently when she returns home. Treatment progression, strength will be progressed by increasing the weights used as well as the repetitions and number of sets completed. Range of motion will be progressed by increasing the degrees and amount of time that she is stretched. Balance will be progressed by introducing perturbations, increasing time required to maintain balance, moving from level to uneven surfaces, and gait training will be progressed by increasing the distance that she ambulates and adding out an obstacle course for her. The patient goals are to be independent with all bed mobilities, ADLs, and transfers. She also wants to be independent in ambulation with assistive device as needed, but she prefers no assisted device if possible. Return to social activities includes bingo, senior exercise classes, as well as returning to family and religious activities. She also wants to decrease pain during rest and activity. Her short-term goals will be achieved in 2 weeks. The patient will be able to perform all bed mobility independent, and patient will be able to bridge with minimal assistance. Patient will be able to perform supine to sit with min assist. She will also be able to stand for 2 minutes with standard walker using weight bearing as tolerated on left lower extremity to improve weight bearing status on her left. Patient will have decreased left hip pain to 1 out of 10 at rest and 3 out of 10 during all activities in order to perform self-care activities as well as participate in church and family events. The patient will be able to ambulate at least 30 feet times 2 using a standard walker, and she'll be increased sitting and standing balance to where the patient can maintain symmetrical upright posture for more than 5 minutes in order to decrease her fall. Her long-term goals, patient will be able to perform all bed mobility transfers and toileting transfers independently using adaptive equipment for toileting and assistance as needed. The patient will be able to stand at least 5 minutes independently with full weight bearing on left lower extremity using a standard cane or min assistive device as needed in order to improve mobility and allow for participation in church and family activities. The patient will decrease left hip pain to 0 out of 10 at rest and less than 3 out of 10 during all activities in order to perform self-care and participate in church and family events. Patient will be able to ambulate at least 50 feet times 3 on level surfaces with necessary assistive device as needed before shortness of breath to improve ambulation, mobility, and independence. The patient will be able to ambulate up and down 6 stairs using a railing and assistive device as needed independently in order to participate in church activities.
Okay, age-related changes. The patient has cataracts, which impairs her vision, which could increase her risk of falling. This is a compensatory age-related change, so she can do things like turning lights on or using other senses like tactile senses or scanning techniques. She also has osteoporosis, so she has a possible fracture risk due to the brittle bones, and she can also compensate by making sure she has a healthy diet and is taking the adequate vitamins. Her equilibrium and protective extension reactions appear slightly delayed, and we can try to restore this by doing balance training. Her comorbidities include congestive heart failure, which may affect patients' endurance, and she has great psychosocial variables because the patient is alert-oriented times 3. She has good memory and concentration and can follow 3-step commands. The patient has family in the area that is supportive. All of these things the psychosocial variables can help with her to progress in therapy.
All right, so the first case is the effects of high-intensity progressive resistance training and targeted multidisciplinary treatment of frailty and mortality in nursing home admission after a hip fracture. It's a randomized controlled trial. So this case included an intervention program for the elderly who have had a hip fracture and surgery using a hip fracture intervention trial, also known as HIP-FIT, to treat patients over the age of 55. And there were 124 participants. The HIP-FIT program included 12 months of high-intensity progressive resistance training, which included 88% of the patient's peak upper and lower body muscle strength for 2 days per week for 12 months. Weightlifting was also started about 6 to 8 weeks after the fracture. A possible limitation to the study was that they did have a smaller sample size than what was expected due to the reductions in funding. They did, as mentioned before, they did have 124 participants. However, they were expecting close to 800 participants. So this case was a randomized controlled parallel group superiority study. Its independent variable was completing the HIP-FIT program for 12 months. The dependent variable was mortality rate, nursing home admission, ability to perform ADLs, and assistive device use. The results were that the HIP-FIT program decreased the risk of mortality by 81%, nursing home admission was decreased by 84%, basic ADLs declined less, and assistive device use was decreased after 12 months. The external validity a strength was that they recruited participants from a public teaching hospital and the surrounding geriatric and rehabilitation hospitals in the area. A weakness was that they had a smaller sample size than expected. Internal validity, the strengths were that they had a control group that underwent standardized treatment, and participants were randomly placed into control or an experimental group. A weakness was that they were unable to specifically state what intervention component provided the most favorable outcome. So for potential future research, would be that they could test the individual components of this intervention for the HIP-FIT in order to determine what component has the greatest impact on the patient's recovery.
All right, mobility training after hip fracture, a randomized controlled trial. This study wanted to find out if a higher dose exercise program would allow for greatest mobility after hip fracture surgery compared to a low dose program consisting of bed and chair exercises. The main findings were that out of the 150 participants that completed the study, the high-dose group had significantly faster sit-to-stand times and completed more steps in the step test compared to low-dose group. Those that had cognitive impairments and were placed in the high-dose group had better outcomes than those without cognitive impairments and in the low-dose group. Both groups had similar results in having an increase in walking speed and knee extensor strength. This study was a randomized control study. The external validity, the sample size which was relatively large, consisting of 150 people. All of the participants were from Sydney, Australia, and findings may be different for other countries. Also, participants were all patients who had surgical fixation for a hip fracture, and the outcomes may be different for other hip surgeries. For internal validity, the primary outcomes assessed were the knee extensor strength and walking speed, and knee extensor strength had good retest reliability in patients that have a hip fracture. Also, rehabilitation that was provided to the patients while getting treatment were only a part of their overall treatment, so the outcomes could be affected by what was provided in other treatments. The program was also relatively short. It only consisted of 16 weeks, and they may not have gotten adequate outcomes from that time. This study was interesting because it shows how walking speed and strength can be increased in patients post-hip fracture surgical fixation with exercises that are weight-bearing and have an increase in intensity, as well as non-weight-bearing exercises. I forgot to mention that the low intensity group only did exercises that were in the bed and while seated, whereas the high dose group did exercises that were all weight bearing and ambulating on a treadmill. All right. The study also suggested those who had cognitive impairments may have better outcomes if treated with weight bearing exercises with an increase in mobility. Clinically, the study can be used to understand that strength and walking speed can be increased for patients post-hip fracture even if it is not high-intensity training. Patients can have increased quality of life by the rehabilitation that occurs while in the hospital after surgery, and it's important for physical therapists to incorporate strengthening exercises and ambulation training within their treatment approach. Potential future research is necessary in establishing the optimal timing, type, and intensity of exercise to increase mobility after a hip fracture.
Okay, so I looked at the time up and go test as a predictor of falls within 6 months after hip fracture surgery, and basically this study had 59 subjects who underwent surgery for the hip fracture in a hospital, and before they left for discharge, they had the time up and go assessed with them. 6 months later, subjects were then interviewed by one physical therapist about any falls to the ground since leaving the hospital. 19 of the 59 subjects experienced one or more falls in the 6 months after discharge. For these subjects that fell, their median tug score was 43 seconds, and for the subjects who did not fall, their score was 29.5 seconds, which was significantly lower. Also, they found that those who were using a higher degree of assistive device, such as a walker compared to a crutch, also had a greater tendency to fall. 15 of the 19 who fell were using walkers when being assessed on a tug. So this shows that a tug can be a good assessment tool to use when using it after hip fracture surgery. So clinically, if you're seeing a patient and they score high on the tug by having a high time, like 43 seconds, then you know there just needs to be more done to be preventative in fall care. So the type of research, this was a prospective study, and for external validity, strength was all participants were from the same specialized unit at the same hospital getting the same treatment for 10 days. Weakness is all subjects couldn't be placed in the geriatrics category. There were a couple of the subjects who were under 65 years of age, so it would have just made it stronger if it could just say all geriatrics. For internal validity, the strength is the tug has strong intra-rater, and retest reliability. So it's a really strong tool to use, and it has so much reliability already. However, after discharge from the hospital, the patient received varying levels of physical therapy. So that could have an effect. So if a person was getting more physical therapy when they left, that could affect their fall risk, may reduce it more than subjects that didn't. So limitations, subjects were only those who were able to perform the tug at discharge. And in order to do the tug, it has to be a moderate functional ability for that. So the lower functional patients were not tested, which would probably have greater fall risks. Also, the sample size was pretty small at 59. So for future research, there needs to be a similar setup, but they need a larger sample size to reinforce the results of the study. And also, they should look at the effects of different rehab plans for those who scored high times on the tug to see what is the most effective in preventing falls.
The program that I decided to look at was a specific inpatient aquatic physiotherapy program to improve strength after total hip or knee replacement surgery. It was a randomized control study, and the primary outcomes that this case looked at were hip abductor strength using a handheld dynamometer, gait speed using a 10-meter walk test, and functional ability using the WOMAC. These were taken 14 days after the initial surgery. One of the advantages of aquatic therapy is that hydrostatic pressure decreases edema. The buoyancy reduces the forces of gravity on the joints and helps to unweight the patient during exercise. The temperature of the water also provides similar effects as thermotherapy, and it may help to reduce pain. The internal and external validity of this case was unfortunately relatively low. Although handheld dynamometers were used to measure abductor strength, the inter-rater reliability varies quite significantly from 0.42 to 0.73, which is less consistent and it's also disregarded in this article. According to the authors, the study was conducted using a private hospital protocol, which was, as it states, under usual clinical conditions. Results cannot necessarily be generalized to other settings. So specific protocols or methodology were not included in this article to show the validity of the actual research. In order to do their program, they had a small appendix that had this as their protocol. So the patient was put in neck-deep water to allow for 10% weight-bearing status. Exercises were performed at a slow pace using a metronome set at 50 to 58 beats per minute. The patient would walk forward 5 minutes, and then postural correction was given for 2 to 3 minutes. Then the patient would stand on a single leg for 10 to 15 seconds and do 10 to 20 reps. March on the spot, 10, and progress to 40 reps. And then they would either put the patient in the pool or on a plinth for 3 to 5 minutes. They performed scissors, bilateral hip abduction, and adduction with floats on each ankle at a slow pace. Cyclic legs, which was basically slow pace. Active knee flexion extension over a float at a slow pace. Supine floating neck was using neck, hip, and knee floats at 10 minutes. Lateral trunk flexion relaxation was performed. Bilateral sculling with arms, as well as gentle, non-specific lumbar spine mobilizations. And then they basically made sure that the patient was standing in neck-deep water again with us to get 10% weight bearing. For 2 to 3 minutes each, the patient would clap their hands, basically doing internal and external rotations at the elbow, elbow flexion and extension, as well as more forward walking. This was the entire treatment that they outlined for a specific aquatic therapy program, and their results were improved aerobic capacity, endurance, and strength, as well as general mobility. This technique can be used during early intervention in order to provide optimal setting for exercise. A specific aquatic therapy program in conjunction with a typical acute care rehabilitation would allow the elderly patients to decrease length of stay in hospitals following joint replacement surgery, and also increase functional mobility in order to allow them to return to activity sooner than protocols that solely rely on inpatient strengthening rehabilitation. Some of the limitations in this article were that there was a very low number of participants who continued through the entirety of this research. There was only 65. No other studies have been conducted to determine the effectiveness of using aquatic therapy in early post-surgical patients within 4 days of surgery. And since both THA and TKA patients were included in this research, the data cannot be used to generalize outcomes for one given patient population. This study actually did a pretty good job at indicating that future research needed to be completed, since aquatic therapy addresses strengthening, gait training, endurance, and functional mobility. These variables would actually be good to have measured following specific aquatic therapy protocols. And further research needs to be conducted to determine the efficacy of aquatic therapy during early intervention, post-surgery, or after falls in the elderly population. Some of the clinical pearls that we found was that social support in elderly population is a big factor for their rehabilitation potential. Don't just focus on restoring what patients lose from their injury, but look to prevent them in the future as well. Don't judge a person based on their age. Some populations can actually do a lot more than you think. And take into account what the patient goals for therapy are, because these might be a motivating force in their rehabilitation.
And these are our references.
Thank you guys for listening.